Look at the EKG findings. So you have ST segment depression, T wave inversion. Okay. So does that mean it's a STEMI? No, you can rule that out right away based on the EKG findings. So it's not a STEMI. If it was a STEMI, you would see ST segment elevation. Is it stable angina? The patient is not really feeling stable, right? They have chest pain, but it's really bad. It's very severe, and you're actually seeing some changes on EKG. You're seeing, there's a lot of stuff going on. If you were to do troponins, CK, MB, those would also start being elevated with this patient. So this would be more consistent with unstable angina. So the duration of this is kind of the tricky one. I think I'll reword this question, so I'll make it so it hasn't been lasting for as long, because the duration is kind of, gearing more towards a MI, like a true actual MI. So I'm going to rewrite that question later and make the duration last a little bit less. So let me actually screenshot that so I can remember to change that later. But it's not a STEMI and it's not stable angina. This would be considered unstable angina. So with unstable angina, you would see ST segment depression and a T wave inversion. All right, now this is where the duration comes into play. So ischemia is reversible, right? So if you were to take that patient with an unstable angina, that's technically going to be a brief period of ischemia, right? But once it hits 20 minutes is when you have irreversible damage to the cardiac myocytes. You're not going to be able to repair those after a 20-minute period of time. So that's going to be an infarct. So that would, if you went beyond 20 minutes, then this patient would be considered a patient with an MI, a true myocardial infarction. All right, does that make sense for you guys? All right. All right, good. Now you guys are getting the hang of it. Okay, so the patient comes in. They've been having pain for 30 minutes, so that's not good. Crushing sensation in the chest. It's radiating as well, kind of like that last patient, but a little bit more severe. This patient has all the hallmarks or the stereotypical risk factors for an MI. On the exam, diaphoretic, so they're sweating. Vital signs, you got hypertension going on. You also have tachycardia. Patient is sort of tachypnic. 20 breaths per minute is like on the cusp of being rapid. And then oxygen saturation, getting close to not being good. Clear lungs are clear on auscultation. So you see ST segment elevation on echo on the EKG. So yeah, so that's going to be consistent with ST elevation MI. So this is a full-blown classic case of a STEMI. So good on that. Most of you guys got it right, so that's fantastic. Cool. So make sure you know your cardiac enzymes. The single most specific of them all is going to be troponin, and it's going to last longer too. CK&B kind of rises along with troponin, but it's going to dissipate a little bit faster. And myoglobin is just really not specific whatsoever, but it shows that you have damage to muscle tissue. So it's one of those questions where I'm not going to get a percentage of who got it correct. So it looks like the answers are kind of across the board here. So yeah, hypotension is not a risk factor. So this was a question, which of these factors is not a risk for atherosclerosis? So read that carefully, okay? So smoking cigarettes is a risk factor for atherosclerosis. Being obese is. Same thing with having diabetes. Those are all risk factors with the exception of hypotension. If you're hypotensive, maybe you're a risk for passing out. That's about it. But you know, having a low blood pressure is only really bad if you're in shock. But some people just have low blood pressure. So it's fine. It's actually better to have low blood pressure than having high blood pressure. Like my mom, for example, she has really low blood pressure. It's normal for her. She is definitely not at risk for atherosclerosis. All right, last one of these. So the reason why the other question that I had with unstable angina, I wanted to change the vignette so it makes it a little more easier for you to follow along. I changed the vignette already, so I've made it so it's like over the past, half an hour or so, the patient started experiencing pain and discomfort and whatnot. But with this question, it's a little bit different. This person is having a myocardial infarction, and for this vignette, the time does matter. It's 90 minutes, so this patient's been having it for 90 minutes. So come test day, I'm not going to be vague with the times. It'll be like if the patient has pain that's going on for like over 90 minutes, it's over 20 minutes, right? That means that the person has an infarct. So I'll make it so it's clear on the actual exam. So it's not going to be confusing. You're not going to have to differentiate between unstable angina versus a full-blown MI. But because the T wave, sorry, not the T wave, but the ST segment is not elevated in this and it's actually depressed, this would be considered a non-STEMI, but it's still an MI regardless. So this would be a non-ST elevation MI. What's up? It's dead. Yes. We talked about that before. So sometimes the patient can recover, right? They'll have diminished function of their heart. If it's really bad and they get treated, they can still get rupture. Remember? We talked about that. So even if you get treated with a transmural MI and you do get reperfusion, the patient gets stabilized, 5, 6, 7 days later, that area of necrosis could rupture and they'll get blood within the pericardial sac. So we'll get Yeah, it's not good. They'll die very rapidly. Otherwise, if a person gets treated after an MI, depending on how severe it is, if it's minimally severe and maybe they get like a coronary artery bypass graft, they could still survive. The heart might not pump well enough. It'll pump well enough for them to live, but it's not going to be like great, right? They're still going to have to take meds. They're going to have to, be on drugs that can help reduce blood pressure. They're going to have be on drugs that would, help thin out their blood, like baby aspirin, things like that. Heart transplant would be another option too. So, yeah, it really depends on the severity. If it's really severe, the person dies. Right? They're not going to be able to survive. So, good question though. All right, any other questions? What's up? I have not. Why? Yeah, I'll have something ready for you guys hopefully the week before. Yeah, I mean, I banged this one out 20 minutes before lecture today because I was like, oh crap, I didn't make any questions for them. So, so I'll try to prep something for you guys. It doesn't take too long. All right. All right. So let's get on with part two. Part two is fun. Part two is going to be more. Part one was good too, but part two is also good. You guys have access to this already, right? I posted this. Okay. Cool. So there's Trent, to answer your question about what can be done. That can be done, right? You can transplant someone's heart, right? So if someone has really bad, severe damage to their heart, you can get a transplant. Other conditions too, you can like if you have dilated cardiomyopathy, you can get a transplant to fix that and whatnot. And now actually, it's getting kind of cool. Like, I don't know if the person still has the kidney in, but it was like the first pig kidney that was grafted for a person, and it was like the longest a non-human organ was transplanted to a person without any sort of rejection. So I don't know if that's still the case, but at the beginning of the semester it was, and it was like the longest ever on record. And there's also decellularized hearts that a lot of folks who are in like biomedical engineering are working on. It's like a ghost heart. They'll remove all the cells, but it'll still have the scaffolding of the extracellular matrix, and then they'll just provide growth factors, stem cells to allow the scaffolding to get filled in, and then they'll use that as a heart replacement. They haven't done it yet, but I'm pretty sure coming up in the near future that's going to be a reality. So, and that's good because the problem with getting a transplant from a donor is that there's rejection. Rejection happens, and then also the person has to be on like a drug like tacrolimus, something like that, which is going to be like a long-term immunosuppressive. And even with long-term immunosuppressives, the patient still can reject the organ. And so that's a very common theme in transplants. But who knows? In the near future, we might see transplants that use the actual patient's cells. So that's a good thing. You will minimize rejection from that. Costochondritis. No. Costochondritis has nothing to do with the heart whatsoever. It is exclusively the cartilages within the ribs or the rib cage, right? So it can look like an MI, but it's not. And yeah, it's totally unrelated. It has usually to do with some sort of like trauma where you got like bruising. If you hear like bruised rib, that's what that is. And so yeah, no link whatsoever to an MI. That's a good question. Any other questions? Cool. All right, so this is that overview of that we talked about before of all the things that we're going to cover. We already covered all these things over here. Now we're going to start covering these things over here. What you see with actual valve defects, the symptoms or the signs and symptoms of valve defects, the different types of murmurs. That is super high yield stuff. And once you get into clinical practice and you get really good at using your stethoscope, you can hear what type of murmur the patient has. and depending on which part of the chest that you're listening to, you can kind of discern which valve is involved. So I think I shared my favorite mnemonic with you guys, the all physicians take money. Did I share that with you guys? So yeah, so when you listen to a patient's heart sounds, all physicians take money. All aortic valve physicians, pulmonary valve, take tricuspid, and then money, mitral valve. So remember that. It's going to help you a lot in the future. So the first spot is the second intercostal space on the right, peristernal. That's going to be the aortic valve. Then the second intercostal space, left side of the sternum, peristernal, is going to be the pulmonary valve. And then if you go to the fourth intercostal space, again, peristernal, that's going to be the tricuspid. And then if you go mid-clavicular line down to the fifth intercostal space, that's going to be the mitral valve. And so if you hear any sort of abnormal sounds like a murmur or something like that, and you hear it like a lot louder in one of those areas, you can kind of figure out where at the heart you're gonna see like a defect on the valve. So for example, if you're hearing around the mitral valve a whooshing murmur between S1 and S2, then you know that the patient might have like a mitral valve stenosis. Sorry, mitral valve regurgitation. So that would be a murmur between S1 and S2. So that means that blood is actually going back into the atria. If you heard around the aortic valve the same type of murmur, a whooshing sound between S1 and S2, that would be aortic stenosis. So some people can actually be born with like a bicuspid aortic valve, and that would cause like stenosis. So you would hear a systolic murmur. So you can figure out if it's systolic versus a diastolic murmur, and also which area on the chest is going to be affected. So we'll talk about the different types of murmurs momentarily here. So this is the normal heart sound, right? You got normal lub-dub, lub-dub, lub-dub. Now, if you remember from way back when you took A&P, that there are two major heart sounds that are normal. The S1 and the S2 heart sounds are normal. During S1 is when you have ventricular contraction, and that's when your AV nodes close. Remember your AV nodes, or sorry, AV valves, that's your atrial ventricular valves. Those are closing. So that means your mitral valve as well as your tricuspid. So that's your S1 sound. So it's the ventricles contracting. And that's the lub of the lub-dub. Then, when the ventricles relax and the aortic valve and the pulmonary valve close because you have blood now kind of flowing back because there's not as much pressure now, those valves close, and that's the dub. So lub-dub. So the lub is the AV valves closing, and the dub are your semilunar valves closing. So those are normal heart sounds. And you shouldn't hear an S3 or an S4. We're going to talk about the different conditions that can cause those extra heart sounds. But these are your normal S1, S2 heart sounds. And so when the heart contracts during systole, then you're going to have you're going to have opening of certain valves and closure of other valves. So when you have systolic contraction of the ventricles, mitral valves close. Right? Mitral valve and tricuspid close. So that's what's going to happen over here. You're going to have pressure building up in that chamber. That pressure pushes against those valves upstream, and those valves are going to close. Downstream, those valves are going to open, right? Because you have a greater amount of pressure in that chamber, and it's going to now move the blood in the direction either into like the aortic valve or through the pulmonary valve. And so that's kind of what's going on with the valves, and that's when you hear those sounds. When the valves close, that's when you hear the sound happening, lub, dub. So the two major murmurs that you're going to hear are going to be murmurs due to stenosis or murmurs due to regurgitation. Now, regurgitation, the most common would be if you have like a mitral valve prolapse, for example, that would cause regurgitation. If you have stenosis, that means that the opening of that valve is very narrow, and it's going to interfere with normal lamellar flow. Remember when you talk about like how the blood flows through your vessels, you have normal laminar flow. If you don't have normal laminar flow, then you're going to get turbulence, right? And when you have turbulence, especially when you're trying to pump blood through a very narrow opening, that turbulence is what causes a murmur sound, right? And generally speaking, a murmur kind of sounds like a whooshing sound. And the murmurs can vary in the degree of like loudness. Like sometimes it can be a very faint murmur. Sometimes the murmur can be really loud. So don't worry about the gradations of murmurs for this class, but just kind of know what's going on in terms of stenosis versus regurgitation. So if you have a stenotic heart valve and it's really tight, what's going to happen with the chamber behind it? It's going to get over, what did you say? It's going to get overworked, right? Because it's trying to push really hard against a tiny opening, and all of a sudden, and over time, you're going to start seeing hypertrophy in that chamber. So, for example, if you had aortic valve stenosis, what's going to happen to the left ventricle? Is it going to get super ripped? It's going to get really, really thick, right? Because it's trying to push against all that extra pressure. If you had, so hypertrophy is going to be the main thing that's going on with stenosis, and you can also see dilation too. So it really just depends. So for the atria, if you had mitral valve stenosis, the atria don't really get hypertrophied, they dilate. So if a person had mitral valve stenosis, right, the mitral valve is the AV valve, right, from the atrial to the ventricle. If you had stenosis of the mitral valve, your atria is going to start getting really big. It's going to start dilating. So you'll get dilation of that chamber. Generally speaking, you're going to see hypertrophy of the ventricles, but not always. You can also get dilated cardiomyopathy, which we're going to talk about later on. Regurgitation. So the biggest thing that's you're going to see with this is prolapse, right? So if you had mitral valve prolapse, that means that the valve is kind of folding in on itself, and now blood is going backwards. It's going like back into the preceding chamber, into the atria. And so that's also going to cause some issues with the patient. But you're not really going to see hypertrophy with mitral valve prolapse. You might see dilation of the atria over time, but you're not really going to see that causing any sort of hypertrophy in the ventricles. Why do you get prolapse? You know, sometimes you can just have defective heart valves. Other times a person might have had a myocardial infarction. Now remember the things that hold the valves in place to maintain structural integrity. What are those structures called? Do you guys remember? Inside the ventricle? Huh? What's the type of tissue that you find in the ventricles? This is going back to AMP. So the atria, you have pectinate muscles. Then inside the ventricles, you have what? Do you remember? Trabecular carinae. Good. So you have trabecular carinae within the ventricles. What are the muscles that hold on to the valve leaflets? What are those called? Papillary muscles. Good. So you have papillary muscles, and they're attached to little tiny strings called what? Chordae tendineae. Good. And the chordae tendineae hold on to the valve leaflets to keep them in place. Papillary muscles during ventricular contraction, those muscles also contract too, and that further stabilizes those heart valves. If you have an MI, and now you have ischemia, or infarct, those tissues, you can see rupture of the papillary muscles. And if you get a rupture of the papillary muscles, now those valve leaflets are going to be flowing right back, right? So you have nothing to anchor that mitral valve in place, and so you can get prolapse because of that. So lots of different things can cause defect on the heart valves. So, and then here's a little bit of a review from AMP. So this is kind of part of that Wigger's diagram, which is a really good diagram that shows what's going on with the cardiac cycle, as well as the different sounds that are involved. But if you were to put a probe inside the heart that measures the pressure, if you put a probe in the ventricle, that's going to be this line over here. So that's going to be your intraventricular pressure. And then if you put a probe in your aorta, that's going to be the pressure in the aorta. And so what happens during ventricular contraction? Right? During systole, you're going to see increased pressure in the ventricle until it reaches a point where finally the aortic valve opens. Once the aortic valve opens, then blood is going to rush into the aorta. As the ventricle now slowly relaxes, then the pressure in the ventricle is reduced, and so now the blood in the aorta can sort of flow back a little bit to the point where it can close the aortic valve. So when the aortic valve closes, that's when you get that S2 sound. So during ventricular contraction, especially in the left ventricle, it's where the mitral valve is. The mitral valve is going to close, and that's going to be your S1 sound. That's going to be your lub. And then when the aortic valve closes, that's going to be your second heart sound, S2, or the dub, in the lub dub. So this is a good diagram that shows everything that's going on there. And here is my little all physicians take money mnemonic. So you can see exactly where you hear the different sounds for the different valves. So for lub dub, because the S2 sound is associated with the aortic valve especially, you would see that pronounced in that second intercostal space. For the mitral valve, when you have the mitral valve closing over here in the lub section, then you would see those sounds being louder especially in the midclavicular line in that fifth intercostal space where the mitral valve is. So, what are the different types of murmurs? So there's two major categories. There's going to be a systolic murmur, and there's going to be a diastolic murmur. So systolic, that's during systolic contraction. So that's going to be between S1 and S2. Okay? Whereas diastolic murmur is going to be when the ventricles relax. And then when the blood starts moving in to the ventricles and you hear a murmur, that would be considered a diastolic murmur. So let's go back to this chart real quick here. So as the ventricle is contracting and you have closure of the AV valves, that's going to be S1. Okay? And so this whole period right here between S1 and S2, associate that with systole. So that's going to be during systolic contraction. So if you have a systolic murmur, that means there's something going on between this section right here where you're having an abnormal heart sound. And so let's think about things that can cause a systolic murmur. So one great example that I already talked about would be aortic stenosis. If you had a stenotic aortic valve, then during systolic contraction, that's when blood is rushing through the aortic valve, then you're going to hear a whooshing sound. So there's going to be, sometimes you don't even hear the S1, S2. It just goes, and if you have like a blowing systolic murmur, that could be associated with something like an aortic stenosis, or it could also be a mitral valve prolapse. And sometimes that will even come with a clicking sound. Sometimes you might hear a click if you have a mitral valve prolapse. Versus diastole, that's during relaxation, right? So that would be between S1 and carrying through here until S2 carrying through to S1. So it would be during relaxation. When would you get that? What kind of valve damage would you see that in? One example would be mitral valve stenosis. So what happens during diastole? When you have relaxation of the ventricles, blood is going to be coming from the atria, and it's going to be passive filling. It's going to go from the atria through the mitral valve and into the ventricle. And during that relaxation period, and if you hear a murmur, that can mean that the mitral valve might be too tight, right? And so it's going to cause disruption in flow. So you'll get a diastolic murmur if you have mitral valve stenosis. And so if you had a patient, for example, we're going to talk about endocarditis on the third section of this series. But if you had, for example, a patient with rheumatic heart disease, rheumatic fever, that's going to be secondary to streptococcal infection. Rheumatic fever is the #1 cause of mitral valve stenosis across the board. So if a patient has mitral valve stenosis, they probably had rheumatic heart disease in the past. And that's going to be post-streptococcal. So we'll talk about that on Friday in more detail. So if you had a patient with rheumatic heart disease and mitral stenosis, you would hear a diastolic murmur. So systolic murmurs, that's going to be between S1 and S2. And then diastolic is going to be S2 to S1. So when you see S2 to S1, that means you're starting here with the heart sound and you're moving all the way until you get to the S1 sound. So with a systolic murmur, you'd hear the lub dub, but between the lub dub, that's where you hear the whooshing sound. Whereas with a diastolic murmur, you hear lub dub whoosh, lub dub whoosh, lub dub whoosh. Okay? So these are the major things that can cause it. So mitral regurg, right? Your mitral valves are prolapsing, perhaps. You're going to have blood going back towards the atria. That's going to cause a systolic murmur. Atrial stenosis, you're going to have a hard time pushing blood through the aortic valve, then you're going to have a systolic murmur as well. Then diastolic murmur, mitral stenosis, and aortic regurgitation. So if you have damage to the aortic valve, you can get regurgitation, which can cause a diastolic murmur too. Are you following the sound? Lub, dub, lub, dub. So after the dub, you hear that whooshing sound. Is it clear to you? Can you hear it? Some of you can't hear it, right? It's kind of hard to hear. So compare that to a systolic murmur. You don't even really hear S1, S2. So this would be like a blowing systolic murmur. So, whereas with the last one, you could hear S1, S2, but after S2, then you heard the murmur. So let's go back to that one again so you can hear it. Come on. Lub, dub, lub, dub, lub, dub, whoosh after the dub. So the more you listen to these, the better you'll get at picking up whether it's a systolic versus diastolic murmur. And it's one of those things that comes with practice. Like when you listen to your patient's heart sounds, you'll be able to catch this over time. Like you'll start getting really good at figuring out if it's a murmur between S1, S2 or between S2 and S1. So, let's listen to some of these murmurs here. Oh, whoops. Hold on a second. So here's normal heart sounds. I don't know if that, I wouldn't really call that a normal heart sound. I'd be a little startled if I heard that. So let's listen to some murmurs here. So we got aortic stenosis. Aortic stenosis would be what kind of murmur? Systolic. Good. So that would be between S1, S2. Awesome. Let's listen to mitral regurg. Is that systolic or diastolic? Systolic. Good. Let's see. What's another good one? Let's listen to mitral stenosis. It's a diastolic murmur, but I don't hear it from this recording. Yeah, that's not a really great example. I don't like that one. Let's see. There's other ones too. You can see like atrial septal defects. So that would be a atrial septal defect. That means between the atria, you have a hole opening. So you might have like a patent ductus arteriosus, for example, that would cause that type of murmur. So you would hear a atrial septal defect. Let's see what a ventricular septal defect sounds like. Would that be kind of similar to a systolic murmur? It's kind of similar to systolic. It sounds like it's between S1 and S2. So let's see. Anything else in here that might be kind of cool? Pulmonic stenosis. Systolic or diastolic? Systolic, exactly. Yeah, perfect. All right. So be familiar with the different sounds that you would hear depending on what kind of heart valve is affected and what kind of disorder is going on with the heart valve. So mitral stenosis, you're going to get diastolic murmur. Mitral regurg, you're going to get that systolic murmur. Aortic stenosis is going to be systolic, and if you had aortic regurgitation, that would be diastolic. And here's a really good outline of what these would look like if you were to draw it out. So this might be something that would help you on test day as well. If you'd like draw S1, S2, and then like scribble in where the sound might be coming from, that would probably help you figure out if it's systolic versus diastolic. So aortic stenosis, here's your S1, S2 sound. Aortic stenosis will be a systolic murmur. Aortic regurg, diastolic. And you've got a patent ductus arteriosus. That's going to be that opening between the two atria. You're going to hear abnormal sounds throughout that. I'm not going to test you on patent ductus arteriosus, though, so don't worry about that one. All right, so here's another chart that summarizes all the different types of conditions that would result in either a systolic or diastolic murmur. So tricuspid regurg. Whenever you have the AV valves being involved and they're regurgitating, then you're going to have systolic murmurs, whether it's the tricuspid or the mitral bicuspid. What happens with tricuspid regurgitation? You're going to have blood from the right ventricle regurgitating back into the atria, right, into the right atria. And so over time, you're going to get a dilated right atria as a consequence. Mitral regurg, similar, right? It's going to regurg from the left side of the ventricle to the left atria. And so over time, you're going to see a dilated left atria. Pulmonic stenosis, so that's from the right ventricle to the lungs or the pulmonary trunk. You're eventually going to start developing hypertrophic cardiomyopathy, and it's going to be hypertrophied on the right side. Now, if you had aortic stenosis, opposite, right? It's going to be in the left ventricle. So the left ventricle is going to have to work really hard, and you're going to get left ventricular hypertrophy. With diastolic murmurs, tricuspid stenosis. So if you had tricuspid stenosis, you would get a hypertrophic right atria. I think we just talked about that. Mitral stenosis. So your mitral valve is, you're not getting enough blood pushing through it. Over time, you're going to get a hypertrophic left atria as well. And then pulmonic regurg, you'll get dilated right ventricle, right? Because the right ventricle pumps into the pulmonary trunk. And if you got aortic regurgitation, you get your left ventricle being associated with that as well. So that's a good chart summarizing all the different things you might see affecting the heart. Cool. So what are some of the things that might cause damage to the valves? Sometimes it can be congenital. Sometimes some people can be born with a abnormal heart valve. But other things can also cause damage too. So we kind of briefly talked about rheumatic fever. We're going to talk about that in more detail next time. Rheumatic fever is secondary to Streptococcus pyogenes, strep throat. So the common story is somebody had strep throat. They didn't get any antibiotics. It resolved on its own. Now, 4 months later, 3 months later, they start feeling tired, weakness, exhaustion, and then they go see the doctor, and the doctor now hears a diastolic murmur. And so that's kind of like a very common theme for rheumatic heart disease. And so that's going to be associated with Streptococcus pyogenes. And if you get mitral valve regurgitation, that's going to be due to prolapse. Oftentimes, it's due to a heart attack. You can get a heart attack causing that. Aortic stenosis, you can be born with that, right? So some individuals might just have that congenitally. You can also get that with rheumatic heart disease. But when you think about rheumatic heart disease, I want you to associate that primarily with mitral stenosis. And with aortic regurgitation, that could be another thing that's you're born with, or it could just be idiopathic. If you get the defects with your valves, you'll hear the murmur. Sometimes the patient doesn't really even know that they have any sort of issue. I've had some people in my family who have had heart murmurs, and they live normal lives. It depends on the severity of it. Right? It depends on the severity of the valve damage. The more severe it is, you're going to get other signs and symptoms like chest pain, difficulty breathing, right? Palpitations, etc. Best way to diagnose would be this guy right here. That's TEE, is a transesophageal echocardiogram. So they literally put the probe down through the esophagus, and they're able to really visualize all the heart valves very well. Ductus arteriosus. Oh yeah, foramen valley. And I misspoke. It wasn't ductus arteriosus that's patent. It's the foramen valley. That's the one between the two different atria. And usually if a person is born with a patent foramen valley, it's not the end of the world. Usually it closes by itself. But for him, you said your friend, why don't they just do surgery? I think they could surgically correct it. Well, the reason why is because if you have blood that's like not moving properly, what happens? Coagulation, right? And so that's the biggest concern with those types of patients. If they have coagulation that's taking place, now they're at risk for an embolus. I want to look more into that, but I would imagine that the greatest risk factor for like death would be embolus. So getting like a stroke or something like that as a consequence of a thromboembolus getting thrown off. Can you find out more about that and share with me later? Because I'm curious to hear about that. Yeah, I don't know what the life expectancy would be for that. I guess if his cardiologist says that, then so they've all failed. Wow, that's crazy. So it's kind of like a ticking time bomb. Yep, crazy. All right, so we already talked about all that. Mitral stenosis, like I said, rheumatic heart disease. I really want you to associate that. Um, Now, if you had mitral valve stenosis, that's going to be a diastolic murmur. When you hear the term decrescendo or crescendo, any musicians in here? There's a couple musicians in here, right? So if you hear, what does crescendo mean? Decrescendo. Yeah, exactly. So crescendo in music, if you read music, you see a little arrow, like two little lines that go louder, right? So that's going to be crescendo. It gets louder and louder. If it's decrescendo, that means it goes from loud to quiet. And so you would start off really loud, and then it would slowly get quieter. Because you have increased pressure in the left atria, the left atria is also going to have increased volume. Then eventually you're going to get dilation, and you eventually could see hypertrophy of that. But dilation will be kind of the biggest thing associated with the left atria. Over time, that can start affecting the lungs, right? If you have buildup in the left atria, and then that's going to also cause buildup in the lungs, you're going to see things like what? Pulmonary hypertension as a consequence, right? So you're going to get extra fluid buildup in the lungs. You might eventually also see like pulmonary edema as a consequence. And then this will be resulting in right-sided congestive heart failure over time. I put this left here. That I would change the L to R because that's what it evolves into over time. Yeah. Oh, sorry. It is left-sided congestive heart failure because if the left side fails, then you get pulmonary hypertension. But this eventually could also turn into right-sided congestive heart failure. So the steps would be left side gets affected, the lungs start getting built. You start seeing edema building up within the lungs, and then that's going to increase the amount of pressure on the right side of the heart, and then over time that can evolve into right-sided congestive heart failure as well. And then when you get the right side affected, then you see all the cardinal signs of right-sided congestive heart failure, like pitting edema as an example. So it could evolve over a period of time. You can see dysarrhythmias happening with mitral stenosis over time when the atria is getting affected. You might see like AFib as a consequence. And then pulmonary hypertension is going to be the big thing there. So let's watch this little video here. Kodiak. Oh no. There we go.
This hollow systolic murmur is best heard in the mitral region, the apex, with radiation to the left axle. On the other side of the heart, a tricuspid valve regurgitation has similar timing and shape, but is loudest in the tricuspid area, and the sound radiates up along the left sternal border. Aortic valve stenosis. When the aortic valve does not open properly and blood is forced through a narrow opening, The blood flow starts small, rises to a maximum in mid-systole at the peak of ventricular contraction, then attenuates toward the end of systole. This results in a crescendo-decrescendo, or a diamond-shaped murmur, which starts a short moment after S1. It is often preceded by an ejection click caused by the opening of the stenotic valve. Aortic stenosis murmur is loudest in the aortic area, and the sound radiates to the carotid arteries in the neck following the direction of blood flow. Again, on the other side of the heart, pulmonic stenosis has the same characteristics, but is best heard in the pulmonic area and does not radiate to the neck. Other conditions that cause audible systolic murmurs include ventricular septal defect and mitral valve prolapse. An example of diastolic murmurs is aortic valve regurgitation. This is when the aortic valve does not close properly, resulting in blood flowing back to the left ventricle during diastole, the filling phase. As the blood flows in the reverse direction, the murmur is best heard not in the aortic area, but rather along the left sternal border. It peaks at the beginning of diastole when the pressure difference is highest, then rapidly decreases as the equilibrium is reached. Other common diastolic murmurs are associated with pulmonic regurgitation, mitral stenosis, and tricuspid stenosis. Thank you for watching. Please feel free to suggest a topic.
All right. That was a really good overview of all that. So mitral valve prolapse and rheumatic heart disease. You can see mitral regurgitation. And so if you had mitral valve prolapse, you're going to get that systolic murmur. You get flow going backwards. And so what's going to happen with cardiac output? Cardiac output is going to go down. Right? You're not filling the heart enough during diastole. And then it's not going, well, you're not getting enough blood pumped through the aorta. So that's going to reduce your overall cardiac output. And then you get that left atrial dilation, and then eventually pulmonary hypertension, and then you can get right ventricular involvement, which would cause right-sided heart failure as well. All right, mitral valve prolapse. By the way, any questions so far, or are we good? So the lady said that there's a click with the aortic valve stenosis. There's also a click associated with mitral valve prolapse as well. So that's one thing to keep in mind about the clicking sound. Now, if you have mitral valve prolapse, it could be an issue with genes. If you have a connective tissue disorder, that can also cause damage on the valves. So a good example would be like for Marfan's syndrome. Marfan's is going to be something that affects connective tissues. It's a genetic disorder. And there's other, like Ehlers-Danlos, where double jointed, very like flexible. Those individuals can have some damage to their cardiovascular system as well, just because it's a connective tissue type disorder. So if you have any sort of connective tissue disorder, it could affect the heart valves. Hyperthyroidism, I guess, can also affect the heart valves, causing mitral valve prolapse. Not as high yield, but when you have regurg from the mitral valve, that's the big thing that you're going to see first is the left atria is going to be dilated. Increased risk of infective endocarditis. Why? What is infective endocarditis? It involves, what do you think it would involve? Like bacteria, viruses? Generally, when we're talking about endocarditis, we're talking about bacterial infections. And what happens when you have damage to the leaflets, bacteria tend to start accumulating in those areas. And so if you have accumulation of bacteria on a heart valve, that's now infective endocarditis. You can get that from bacteria. You can get that from fungi too. I told you guys the story about my candida patient who was like spitting in her IV line, right? And so she had infective endocarditis due to candidiasis. So that was a fungus that caused that. But really, common organisms would be Enterococcus faecalis is one. That's something you find in your GI tract. If that gets attached to the heart valves that can cause infective endocarditis. You can see that with strep pyogenes, with the rheumatic heart fever. The biggest concern with infective endocarditis is stroke, right? It's getting a septic embolus. I mean, it's going to cause damage to the heart too. That's a big concern as well. But another startling concern would be getting emboli, right? So that would be one thing to watch out for. Sounds good. All right, so let's begin with hypertension and blood pressure. So blood pressure is one of the 4 major vital signs, right? What are the 3 other major vital signs? Pulse rate, respiratory rate, temperature. Good. So blood pressure, heart rate, respiratory rate, temperature. Some people throw in pain as one of the 5th vital signs, or a 5th vital sign, rather. And it really depends on what the patient is actually experiencing, right? So if a patient is experiencing acute MI, they're going to be in a lot of pain. So you want to treat them with pain meds. Morphine is going to be standard protocol. So monotherapy. So morphine, oxygen, nitroglycerin, and aspirin. That's going to be what you treat a heart attack with. So pain is a good, marker that you want to consider. You want to consider that. So, if the patient's in severe pain, you want to be able to treat that with analgesics. Don't be too aggressive with treating pain because, 20 some years ago, the pharmaceutical industry convinced a lot of the medical community that there was no risk in drugs like OxyContin. And so now we have the downstream consequences of all that. I forget what company it was. Was it Purdue Pharma? It was one of those pharmaceutical companies. Massive class action lawsuit. They had to pay, I think it was billions of dollars in reparations for everything, for all the damages that they caused. And it was all based off of really bad science. So pain is kind of like a sticky type of situation when it comes to therapy. Like you definitely want to treat it, right? You want to treat a person who's in pain. But also you don't want to just be giving out drugs unnecessarily. So that's why we have the fentanyl crisis now, is because a lot of those people, they were getting prescribed pain meds. They were doctor shopping as well, going from physician to physician, trying to get pain meds. So pain is kind of a controversial issue in that regard, but it is a very important thing to consider. You want to be able to manage a patient's pain. So let's talk about hypertension. So hypertension now is going to be anything above 130 over 80. So systolic of 130 and a diastolic of over 80 is going to be considered hypertensive. So these guidelines changed since I went to med school. When I went to med school over 10 years ago now, the guidelines are a little bit different. So there was pre-hypertension, and then there was hypertension. Back in those days, pre-hypertension was anything between 130 to 139. Nowadays, this is considered hypertension, but it's stage 1 hypertension. So systolic 130 to 139, that's stage 1. If it's diastolic 80 to 89, that's also stage 1. Stage 2 is going to be 140. Anything above 140 or above 90 diastolic, that would be stage 2 hypertension. And then hypertensive crisis, this is where things are getting really bad. If a person's having a hypertensive crisis, they're going to start getting end organ damage. They can get damage to like their glomerulus. They can get damage to the kidneys, glomerular nephropathy. They can also start having a higher risk for stroke, ruptured like aneurysms, things like that. So these patients need to be treated ASAP. If a person has a hypertensive crisis, they need to go to the emergency room. They need to go see their doctor. They need to get medication to bring that blood pressure down. Otherwise, you're going to see some significant damage if that's left untreated. What causes hypertension? So sometimes it could just be things you can't control, right? Age, the older you get, the more likely you are to develop hypertension, right? So that's kind of falls in line with like atherosclerosis, where you have hardening of the arteries over time, even with the elastic tissues within your arteries. Sometimes the elastic tissues just start to degrade over time. And so just by getting older, you're going to be a little bit more at risk for developing hypertension. African Americans are generally going to run more hypertensive as a demographic. And patients with diabetes. Of course, with diabetes, you're going to be causing a lot of damage to several tissues in the body. In terms of like the vascular system, if you have lots of uncontrolled blood glucose, you have too much sugar, you're going to increase the amount of fluids that are going to be retained, right? So it might actually cause hypertension just by virtue of the amount of fluids, because glucose is going to attract fluids, so it makes it more osmotic. Arthrosclerosis, hardening of the arteries, obviously is going to cause hypertension. Anxiety, if somebody is constantly stressed out, that stress puts them into a sympathetic state. So lots of stress is not good. Stress can cause heightened sympathetic state, but think about cortisol. What does cortisol do when it's released from the adrenal cortex? What's another term for cortisol? What does it fall under in terms of categories? Do you remember like mineralocorticoids versus glucocorticoids from AMP? So mineralocorticoids would be like aldosterone. Cortisol is a glucocorticoid. And when cortisol is released, it actually elevates the amount of glucose in the blood. So you do see glucose elevation with cortisol release. So if you're in a constant stress type of situation where you're like constantly stressed out, you're going to have extra cortisol release. That extra cortisol is going to make you a little bit more hyperglycemic. And glucose is very damaging, especially over a long period of time. Increased sodium, obviously because of osmosis, water follows solutes. So if you had a lot of aldosterone being secreted for whatever reason, then you're going to increase your sodium levels, which can be a good thing if it's part of like the renin-angiotensin-aldosterone system. But then if you have a really high sodium diet, I have a cousin back in Brazil, really awesome guy. His wife is a total sweetheart. I stayed with him for a week, and I just couldn't believe it. Like, everything they cooked was so freaking salty, and I just like didn't have the heart to tell them like that it was absolutely difficult to eat, but so I ate it anyways. And just putting too much salt in your diet is not a good thing, right? Salt is a good thing when it's up to a certain extent, right? You gotta have a little bit of salt. It balances things out. But too much salt, not a good thing. So I'm pretty sure if I were to take their blood pressure would probably be pretty high by virtue of the fact that they consume way too much sodium. So salt is another thing that can increase your blood pressure. And then kidney disorders can also cause hypertension. So if you had if you had renal disease, like if you had to go on dialysis, that would also cause hypertension, because if you have like stage 4 renal failure, you're not going to be excreting urine, right? You're going to be retaining fluids. And by virtue of retaining fluids, you're going to increase your blood volume, which thereby increases your blood pressure. But also, if you have any sort of disorder that causes problems with the renin-angiotensin-aldosterone system, that's going to increase aldosterone, which increases sodium, and it's going to increase angiotensin 2. And angiotensin 2, if you remember from AMP, is a very potent vasoconstrictor. So if you vasoconstrict, you increase your afterload, you're going to increase your total peripheral resistance, you're going to increase your blood pressure as a consequence. So these are the major things that are going to affect your blood pressure. Generally, when you have hypertension, you don't really notice it until it's long-standing and it's too late and you start getting end organ damage. But if you get to this hypertensive crisis situation where it's really high, then you're going to really start seeing symptoms. That patient is going to complain of a headache. That's scary. If you have hypertension with a headache, that means that you're like very close to potentially getting a stroke. So you definitely want to treat that. You might even see blurry vision because you have lots of vessels within your retina. And if those vessels are getting affected by high blood pressure, that's going to affect your eyesight. And if it's really bad over a long period of time, you could even start getting like blindness as a consequence of hypertension. Epistaxis, that's just a fancy word for a nosebleed. So if you have really high blood pressure, you might see nosebleeds. And then diaphoresis is just sweating. If it's also really bad, you might see the heart getting involved, so you might see arrhythmias. But the big thing here with complications, aneurysms, right? Aneurysms, we're going to talk a little bit about aneurysms when we get into neurology as well. So aneurysms are where you have weakening of the blood vessel and it's like bulging out, right? And those are going to be a high risk of rupture. So a common one that you see for subarachnoid hemorrhages will be a ruptured berry aneurysm, right? right? And that's one thing that you could, some people just have those and they don't even know it. Sometimes it might not even be related necessarily to hypertension. They might just have like a faulty vessel. But if you increase your blood pressure, that increases your risk for developing aneurysms. You could see heart failure, stroke, vision loss, all that stuff. So kidney failure can be a consequence of hypertension as well. Lots of your patients that you see in dialysis, it's like one of two things usually. It's one, diabetes, or it's two, hypertension, untreated. And those are the two major things that usually result in end-stage renal disease. And those patients have to go through dialysis. And dialysis is not fun, right? You're in the dialysis unit 3 times a week. Every single time you go, it's a 4-hour session, being hooked up to a machine that filters out your blood, and it's exhausting, and you're basically kind of useless for the rest of the day. It's not a good situation to be in. You want your kidneys. Testing, obviously clinical, right? You just take a blood pressure test on these patients. I think it's 3 times in a row. If it's elevated, then you can diagnose them officially with hypertension, at which point you want to start considering, first you want to consider lifestyle modification. Tell them diet, exercise, reduce sodium, right? So those are some of the major things they can do for lifestyle. But if those fail, here in the United States and in Western countries, we like drugs, right? We love drugs. We don't like to treat the underlying cause. So we don't really do preventative medicine as much as we do reactionary medicine. So we react when the thing has already happened. And so oftentimes we just medicate these patients. We give them beta blockers. We'll give them statins, ACE inhibitors. So yeah, that's usually how we treat it. So you can treat it with meds. You also want to rule out other causes that might be underlying hypertension. So if they have like renal artery involvement that can cause hypertension, there's other conditions that can cause hypertension. Think about like thyroid, right? The patient might be hyperthyroid. If they have hyperthyroidism, that's going to elevate their blood pressure as well. So there's several things that can cause hypertension that might be just outside of controllable factors. It might be just part of the patient's genetic makeup. So there's different types of hypertension. There's essential or primary hypertension. That means that we don't know what's going on. The biggest risk factor for this is going to be family history, right? I have friends who have really high blood pressure. My best friend, he has high blood pressure. And so it runs in his family. He does a lot of things that he shouldn't do. He smokes a lot. He drinks a lot. So those are all things that contribute to it. But regardless, even other members in his family that don't drink and smoke, they also have hypertension as well. So that's just something that runs in the family for some people. If you have any disorder with the renin-angiotensin-aldosterone system, that's going to cause hypertension. Aldosterone, sodium, right? Angiotensin 2, vasoconstriction. If you have anything that's affecting the sympathetic nervous system, vasoconstriction, that's going to increase your total peripheral resistance. That increases your blood pressure. If you have atherosclerosis, of course, it's going to increase your blood pressure. Now, secondary hypertension, that is something that you can identify what the underlying cause is. If it's secondary hypertension, it's going to be secondary to something else, right? So kidney failure would be one example. If kidney failure, you're not going to produce urine. You're going to accumulate fluids. People who have end-stage renal disease are not allowed to drink much at all. They can do ice chips, right, to help like wet their palate, but that's kind of it. You want to minimize fluid intake for patients with renal failure. So sodium, so we talked about the renin-angiotensin system. So if you reduced sodium excretion, increase the reabsorption, that's going to increase the osmolarity of your serum. That is going to drive water back into the system, right? So you're not going to excrete that water. You're going to retain the water. All right, any questions on hypertension? All right, let's briefly talk about metabolic syndrome or syndrome X. We usually call it metabolic syndrome, though. Metabolic syndrome is associated with cardiovascular disease, diabetes, and other things as well. So it's a lot of things contributing to metabolic syndrome. So just a quick brief note before we talk about all this stuff over here. There are certain lifestyle factors that contribute to metabolic syndrome. So a lot of you are going to be nurses someday. And a lot of you are probably going to do night shifts and shift work, and you're going to have just really wild schedules. So sometimes you might be working during the day, sometimes you might be working at night. And when you throw off your circadian rhythm, there's been lots of research showing that throwing off your circadian rhythm predisposes you to this, metabolic syndrome. So that's one thing. Other thing could also be drugs. There's certain medications, a lot of your antipsychotics, a lot of your depression meds, side effect, metabolic syndrome. So I think I talk about the drugs here, if I remember correctly. Yeah, I don't talk about the drugs here. So here's one story about the drugs. Abilify is an antipsychotic drug that's used as well to treat depression. So it can be used for patients with schizophrenia, and it can also be used to treat patients that have like depression. Ex-girlfriend of mine, she was totally nuts. She was seeing her psychiatrist for her depression, and she told me, "Oh yeah, they prescribed Abilify." I told her, "Throw that away. Throw away the prescription." Because Abilify, one of the major side effects of Abilify is metabolic syndrome and weight gain. And what's a better way to make a young girl even more depressed than she already is by making her gain weight? So I told her, just like, throw it away. There's way better drugs out there to treat depression that don't have a severe side effect. But unfortunately, pharmaceutical companies and their reps, they'll send reps out, be like, hey, use this drug to treat, whatever disease. And sometimes the side effect profile sucks, right? Sometimes the side effects are worse than the actual disease that you're treating. So I told her to throw it away. I probably should have let her stay on it because I don't like her very much anymore. Anyways, so what's metabolic syndrome? You have to have these things happen, right? You have to have 3 out of 5. So waist circumference for guys, 40 inches, for gals, 35. High triglyceride levels, high LDLs, so dyslipidemia, whether it's triglycerides or LDLs. Your blood pressure has to be high too, so pre-hypertension, but in reality it's actually hypertension. Yeah, that would actually be hypertension. I need to fix that. This is old school. This is actually old, pre-hypertension. We don't use that anymore. So this would actually be true hypertension. So I need to update these slides to reflect that. And then a fasting glucose of above 100. That means that that person has insulin resistance. So if you have a fasting glucose, you go to see your doctor, you haven't eaten anything that morning, fasting glucose should be below 100. If your fasting glucose is between 100 to 125, that is insulin resistance, right? That's pre-diabetic. If you're above 125, that's diabetes on a fasting glucose. So all these things would contribute to metabolic syndrome. You have to have 3 of these 5 to qualify. All right, so let's briefly talk about orthostatic postural hypotension, and then I'll make a very brief note on POTS, which is positional orthostatic tachycardia. Orthostatic hypertension or hypotension. What's going on with orthostatic hypotension? If you are laying down for a little bit or seated for a while, and then you rapidly get up, and then the blood rushes down to your feet and out of your head, that would be orthostatic hypotension. And so if your blood pressure, if your systolic and diastolic pressure on standing is changes by 20 millimeters of mercury for systolic, or by 10 millimeters of mercury for diastolic, standing versus sitting down, then that would be considered orthostatic hypotension. If you have a jump of 20 millimeters of mercury in your systolic, that's a massive jump of blood pressure. So that would be considered orthostatic hypotension. So orthostatic just means your position, right? Whether you're laying down or seated. And you're not going to have a good compensation in changes to this blood pressure change, right? So if your systolic drops by 20 millimeters of mercury, you're not going to be able to compensate for that. Your blood is going to start pooling down towards your feet. It's going to drain out of your head, and sometimes you can even faint as a consequence of this. So you can have syncope as a consequence. So you can get fainting upon standing. So that's the big thing there. So here is positional orthostatic tachycardia. So this is a little bit different. This is POTS. So a little bit different than orthostatic hypotension because positional orthostatic tachycardia is involving the heart. So what's going to happen here is that if you're standing for too long, blood is going to pool down to your lower extremities. Or if you get up too fast, same thing, right? Blood's going to pool. But then your heart is going to try to compensate. So your heart starts beating really rapidly. So you're going to get tachycardic. And so this is POTS, positional orthostatic tachycardia. I have one student that has this, and I took her blood pressure the other day for my medical physiology class, and it was pretty low. It was about 108 systolic, 76 diastolic. So that's actually pretty good. She said that usually it's way lower than that, but now she's on drugs. She's taking meds that are alpha-1 agonists, so it helps the vasoconstrict. And she's also modifying her diet too. So with patients with POTS, they have to have dietary modification. They actually want to increase their sodium levels because if they have increased sodium, it increases their blood volume and it prevents this from happening when they change position. So they want to increase fluids. They want to increase salt. They want to avoid standing up for too long of time. And yeah, those are the major things that you can do to treat that. You can also take drugs that can help increase sympathetic tone. So drugs that can allow for vasoconstriction. Any questions on that? Does anybody in here know anybody with POTS? There's another student that I had this morning who gets crazy fluctuations in her systolic. She was in my A&P this morning, and we were talking about blood pressure or heart rate. And her heart rate, just sitting like you guys are sitting right now, was 135 beats per minute. That is really fast. And she was talking about it in class. I'm like, that's really fast. And she was asking for my advice. I'm like, I'm not your doctor. I can't give you medical advice. But you should probably go see somebody about that because you shouldn't have a resting heart rate of 135. And then I told her to do a carotid massage. So I had her do the baroreceptor reflex trigger. And apparently it dropped it quite a bit. It went down to like 105 or something like that. But massive fluctuations. It's not a good sign. There's something else going on there with that student. But yeah, these things happen to individuals, and sometimes it's idiopathic. Like we don't really know exactly why that's the case. All right. So I'm not going to test you on like how to calculate ejection fraction. First of all, it involves division. I'm not going to make you guys do division since you can't use calculators in this class. But it's good to know what ejection fraction actually means. So ejection fraction is the amount of blood that's getting pumped out of your heart in one beat. So the way that you calculate that is you want to know your stroke volume. And so remember, stroke volume is end diastolic volume. That's the most amount of blood in your heart. And then end systolic volume is when you have the least amount of blood in your heart. So to calculate stroke volume, you subtract end systolic from end diastolic volume. And on average, it should be roughly 70 milliliters, right? So it's actually not that much. I think we talked about it before. It's like a little bit more than a shot glass. Shot glass is 50 mLs of fluid. A little bit more than a shot glass is 70 mLs of fluid. That's how much ideally should be getting pumped out of your ventricles. Then if you want to calculate ejection fraction, you're going to take your stroke volume and you're going to subtract that from your end diastolic volume. So in other words, you're going to see how much blood actually got pumped out, and then you're going to see how much that is in relation to the end diastolic volume. So people should have a stroke volume of somewhere between 50 to 70. That's kind of the ideal range. Once you get below 40 ejection fraction, if it's below 40%, that's when you start seeing problems like symptoms. You might start getting exhaustion, fatigued, lethargy. You might start getting, shortness of breath, right? There's lots of things that you might see with a patient with really bad stroke volume. So the worst one I saw was a patient with dilated cardiomyopathy, right? When you get a really big heart, it's hard for the actin and myosin filaments to cross over each other. And so his stroke volume was around 20-ish. And I was talking to my colleague, Dr. Jackson, last year, and he said the worst he ever saw was like somewhere around like 15 or something, maybe more than that a little bit. But once you get below 15, it's kind of not compatible with life. So I'm gonna have to ask him exactly how bad that ejection fraction was in this patient. But usually when you have an ejection fraction below 40%, that's not a good situation. So let's talk a little bit about heart failure now. So there are two types of heart failure. There's going to be right-sided versus left-sided heart failure. With left-sided heart failure, where does the blood get pulled back into? Where does it back up? Yeah, it backs up in the lungs, right? So if blood is backing up in the lungs, then you're going to get pulmonary edema. So it's going to be hard for you to sleep, laying down. You're going to have shortness of breath. So that's what this word is, orthopnea. Orthopnea means difficulty breathing when laying down. Okay, so it's positional. Let me play a video. I didn't include it on your guys' slides, but it's on my pre-meds. It's in their slides. Hold on 1 second. Yeah. It's a fun video.
Hello everyone, today we are going to understand the difference between dyspnea and orthopnea. Dyspnea means it is the difficulty in breathing or shortness of breath, whereas orthopnea means it is the difficulty in breathing whenever the person is lying down. Or else we can say that orthopnea means it is dyspnea when lying down. Thank you for watching. Subscribe for more such videos.
All right, sorry, I absolutely had to play that video. So that dude is so cool. Okay, so yeah, orthopnea, difficulty breathing laying down. Okay, so if you have too much congestion in your lungs and you can't breathe laying down, something that you might see the patient doing is propping themselves up with pillows. So you could ask the patient, oh, how many pillows do you need to use to lay down when you're sleeping at night? Because it's going to be hard for them to remain prostate, right? So they're going to have to kind of be at an angle when they're laying down to sleep. And so that's one thing you can, try to assess on the history of what the patient's going through. You might also see tachypnea, so that's going to be breathing fast. You might see the person coughing, wheezing, crackles if you listen to auscultation. Right-sided heart failure is going to be a little bit different. It's going to be systemic, right? Or systemic, rather. Systemic edema. So you're going to see that especially in the lower extremities. You're going to see bilateral pitting edema in those patients. So right-sided congestive heart failure, it's going to be backing up into the rest of the body. Can left-sided congestive heart failure eventually evolve into right-sided congestive heart failure? Yes, it absolutely can, right? Because if you have left-sided congestion, it's pulling up into the lungs. What's that doing to the right side of the heart? It's making the heart beat harder because now the heart has to try to push against all that extra pressure. And over time, that can result in right-sided heart failure as well. And then you would see the right side type symptoms. You would see systemic edema, right? Especially bilateral pitting edema. Cor pulmonale is going to be another big thing that you see with the heart. That's where you have hypertrophy of the right side of the heart. And with cor pulmonale, you'll see like congestion of blood from the right side of the heart, and you can even see jugular venous distension. Your jugular vein, you're not supposed to see it pulsate. But with the patient that has cor pulmonale, you'll be able to see when they lay that back a little bit, you'll have them lay back at an angle in their bed, and you'll take a look at their neck, and you can see the jugular vein pulsating. And you're not supposed to see that normally. But you will see that in patients with cor pulmonale. What this video is here. This is with the heart sounds. Okay, so before I play S3 versus S4 heart sounds, so let me actually exit out of that, and then I'm going to kind of go over what's going on here with systolic versus diastolic function. If you have systolic function, that's going to mean that during systole, you're not getting a good contraction. What's the heart condition that causes that? It's right there. So if you have a dilated heart and your myocyte and actin filaments are not able, sorry, your actin and myosin filaments are able to go over each other properly, and you can't get a good contraction, that's called a systolic dysfunction. That means during systole, the heart's not pumping properly. And so with dilated cardiomyopathy, as well as Takotsubo, which we'll talk about a little bit later, you're going to get an S3 heart sound. And the way that these heart sounds are labeled, the normal heart sounds, the lub-dub, right? Lub meaning the AV valves closed, dub meaning that the aortic and pulmonic valves closed. Those are S1, S2, so lub-dub. If you have S3, that's directly after S2. So you call this a gallop rhythm. So it sounds like lub-dub-dub, lub-dub-dub, lub-dub-dub. Versus an S4 sound, it's right before S1. So it'd be like lub-lub-dub, lub-lub-dub. It'd be like lub-lub-dub. So you have like gallop rhythm. So it's like 3 different sounds, 2 of which are supposed to be normal, but that third one is not supposed to be there. So systolic. There's 3, this is one way for you to remember this. There are 3 syllables in systolic. Systolic. S3 heart sound. Diastolic is 4 syllables. Diastolic. 4 syllables. S4 heart sound. So what's a diastolic dysfunction? Diastolic dysfunction means that there's not enough blood filling into the heart during diastole. How can that happen? You might have hypertrophic cardiomyopathy, right? You might have a lot of extra muscle in the heart, and now the chamber is smaller, and so you're not getting enough blood filling into that chamber. So that's one thing you can see. You can also see that with fibrosis of the heart. So restrictive cardiomyopathy can cause that. Hypertrophic cardiomyopathy can cause that. So let's listen to what these sounds might sound like, and they're very difficult to perceive. So ba-dum-bum, 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 ba-dum-bum. Bum 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 bum. Are you having a hard time hearing it? It's hard to hear, isn't it? So yeah, extremely hard to hear. But you can pretend it's there. Just know if you see on a vignette or something like that that says patient has an S3 heart sound, know that's a systolic dysfunction. It's probably going to be dilated cardiomyopathy. Patient has an S4 heart sound. Okay, cool. Maybe they have restrictive cardiomyopathy or hypertrophic cardiomyopathy because S4 is going to be a diastolic dysfunction. Luckily, you don't have to listen to anything on the exam, right? You don't have to listen to heart sounds. Cool. So, congestive heart failure summary, right? If you have left-sided, it's going to involve the lungs, your orthopnea, pulmonary congestion. Right-sided, you'll see especially systemic edema, bilateral pitting edema. What are the causes? There's a lot. There's atherosclerosis, coronary artery disease, hypertension, cardiomyopathy, valves, if the valves aren't working properly, if you have arrhythmias, anemia, drugs, diabetes, collagen issues, nutritional deficiency, so thiamine, vitamin A, calcium, magnesium. If you have a lot of congestion in your heart, you're going to get the release of brain or B-type natriuretic peptide. So that's one thing. What does BNP do and AMP? They both do something similar. What do they do with sodium? Do they retain sodium or do they release sodium? They're going to do the opposite of aldosterone. They're going to do the opposite of aldosterone as well as ADH. So aldosterone brings on sodium, right, to increase your blood volume, to increase your blood pressure. ANP and BNP are both going to secrete sodium, so you bring the blood pressure down. And so you've got a lot of congestion in your heart. Because of that, there's going to be more pressure in the heart. That's going to stimulate the heart to release BNP. And so you can actually test for this in the lab. So you can test this to diagnose the patient with congestive heart failure. They're going to have elevated BNP levels. And then cor pulmonale, that's where you have right-side involvement. So look at this slide over here with the image with the heart. You got massive hypertrophy in your right ventricle. And if you have hypertrophy, enlargement of the right ventricle, that's how you see cor pulmonale. Things that can cause it: COPD, right? You're going to have increased pulmonary. You're going to have like pulmonary hypertension, and so you're going to be trying to pump up against extra pressure with COPD. So that's going to cause hypertrophy of the right side of the heart. Cystic fibrosis, something else that can cause right-sided heart hypertrophy. Pulmonary fibrosis. Fibrotic tissue is a restrictive lung disease, and so it's really hard for the lungs to inflate. But on top of that, the vessels are also going to, you're going to see higher blood pressure in those vessels too. And then, of course, pulmonary hypertension, you're going to see this. Dyspnea, they're going to be cyanotic because they're not getting enough oxygenation, right? Because you're trying to pump blood into the lungs to get oxygenated, but you're having a hard time doing that. And so you're not getting enough circulation through the lungs. So you're not getting proper oxygenation of the blood. So you're going to get cyanosis. JVD, ascites. Ascites is fluid buildup in the peritoneum, in the abdomen, and then edema. So you can obviously see this on an echocardiogram. You can literally visualize that on an echo. You can do it on a chest x-ray as well. And then an angiogram would also allow you to see that. So this is the patient's jugular vein. You are not supposed to see this happening under normal circumstances. That is massively dilated, and the pulsation, that's jugular venous distension. You could like elicit this even further if you were to push on the patient's liver, right? So then you're going to be placing extra blood pressure to the right side of the heart, and so that can actually make this even more pronounced on the jugular venous distension. But yeah, so that's JVD. All right, let's switch gears a little bit and talk about the different types of cardiomyopathies. So these are the major ones. So you got hypertrophic cardiomyopathy, you have restrictive cardiomyopathy, and then you have dilated cardiomyopathy. If it's hypertrophic, that means it's really thick, right? You got a big buff heart. And that's not a good thing. You don't want your heart to be super thick and hypertrophy. That's going to result in a diastolic dysfunction. That means during relaxation, the chambers are not going to be big enough to accommodate the amount of blood that you need. So you're not going to get enough blood in there. So that's why it's referred to as a diastolic dysfunction. What kind of heart sound would you hear with that? S4, good. So S4 heart sound. Restrictive, stiff walls. So if you have a really stiff heart, we'll talk about that in a little bit later, what might cause that. If you have a very stiff heart, that's going to also cause a diastolic dysfunction. You'll also hear an S4 sound with that type of patient. If it's dilated and it's really big, like you see in this image over here, super inflated, like a balloon. The walls are even going to be thinner than normal because it's being stretched out. So dilated cardiomyopathy is going to be a systolic dysfunction because you're not going to get a proper contraction when it's too dilated. And so with a systolic dysfunction, what kind of heart sound? S3 heart sound with systolic dysfunction. So what kind of things might you see in terms of symptoms? Dyspnea or difficulty breathing, exertion, dizziness, lightheadedness. You might also see edema, arrhythmias. You might see palpitations. You might actually be able to feel your heart beating. That's what a palpitation is. You can actually physically feel your heart beat. And then syncope. What's syncope? What happens if a person has a syncopal episode? They what? They fainted. They passed out. So this would be cardiogenic syncope, because there's also neurogenic syncope as well. So if you pass out, that's syncope, and if you have a cardiomyopathy, that could cause syncope. You can test this with an EKG. You can see areas that might be hypertrophied. You'll see like exaggerations in all the waves and stuff, like the QRS complex, etc. You would be able to visualize this very well with an echocardiogram. And then chest x-ray, you'd be able to see the cardiac silhouette would be increased, right? Because this heart is bigger. And so you'd be able to see that on chest x-ray. And then again, B-type or brain natriuretic peptide would be elevated in those patients. So let's start talking about dilated cardiomyopathy. What is the main risk factor for dilated heart? Alcoholism. So if you're chronic alcoholic, you might eventually develop dilated cardiomyopathy. The patient that I had, he was a chronic alcoholic. So say, for example, you're drinking like 20 beers a day or something like that. That eventually over time is going to cause dilated cardiomyopathy. One of my supervisors back when I was doing my clinicals was talking about dilated cardiomyopathy. One of the main ways that happens is you have so much fluid from all the booze you're drinking. Like, say you're drinking 20, 25 beers a day or something like that. That's a lot of fluid. And so over time, all that fluid is going to kind of put some extra stress on the heart. So that's one thing. But also drug toxicity can cause it. So certain drugs can cause dilated cardiomyopathy. If you have an ischemic heart disease after a heart attack, then that can damage the cardiac myocytes, so it gets all massively dilated. And this is what you would see on an x-ray. So here's the silhouette. So that's the cardiac silhouette. This is normal. This is huge. Right? So that's a really big heart. Not a good situation. Sequelae just means the downstream consequences of a disease. So what's the sequelae of dilated cardiomyopathy? Heart failure, dysrhythmia, and because blood might be pooling, because you're having a hard time pumping it out, when blood sits there for a while, it's going to start to coagulate. And so these patients are a high risk for embolus. So like a stroke, for example, would be one of the more serious types of emboli for these types of patients. Here's an image of what these hearts might look like when you remove it from a person's body. Just absolutely freaking massive. It looks like a giant balloon. All right. Any questions on those? So let's talk about hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy, you're seeing the ventricles especially being involved in this. So the ventricles get super hypertrophied, and because of that, you're going to have a difficult time filling this space up with blood. Right? See how thick these walls are. Look how narrow the ventricle chamber is. It's very tiny. So you're not going to get very much blood in there. So that's why you refer to this as a diastolic dysfunction. Because it's a diastolic dysfunction, you get an S4 heart sound, and but you also might see a normal ejection fraction. So you will get blood in there. You'll be able to see an ejection fraction that seems normal, but in reality, because the end diastolic volume is actually low, then you're going to see, it's going to look like a normal ejection fraction. If you have any questions about that, we can go back to the equation on ejection fraction. So here's your ejection fraction. Because the denominator is going to be end diastolic volume. The end diastolic volume in a hypertrophied heart is actually going to be really small, but ejection fraction is a ratio, right? It's a percentage. And so if all the values are diminished, then it's going to look like a normal ejection fraction. But in reality, you're actually pumping out less blood than you normally would. So it looks like it's a normal ejection fraction. So it might say 70% ejection fraction, but in reality, it's actually still pretty minimal. So let me go back to that. Versus dilated, you're going to have a low ejection fraction. You're not going to be pumping much blood out of that heart. So these are the two major types of hypertrophic cardiomyopathy. You have the hypertrophic obstructive and then the hypertensive hypertrophic. This one over here is the scary one. The hypertrophic obstructive cardiomyopathy is scary because it involves young people, usually. Young athlete has no previous medical history, healthy, right? They're athletic. All of a sudden, while they're in a sport on the field, they drop dead from sudden cardiac arrest. So that is a common clinical vignette for these types of patients. So if you hear about a young patient, like, I don't know, 20 years old, athlete, maybe playing football or basketball or something, and all of a sudden just drops dead, you can probably bet that this kid had hypertrophic obstructive cardiomyopathy. That's something that they're born with. And they don't know that they have it until they literally drop dead. And so it's an autosomal dominant disease, and it's going to be sudden death in young athletes. So if you see sudden death, you can wager a bet that's going to be hypertrophic obstructive cardiomyopathy. Hypertensive hypertrophic cardiomyopathy is secondary to hypertension. So think about your left ventricle. If you have long-standing hypertension, your left ventricle is having a really hard time pumping against all that pressure, against the systemic circuit. And so over time, the left ventricle starts to get hypertrophied. And so that would be hypertensive related. So that's why it's not this type. It's not hereditary per se. It's due to hypertension. It could also be valve stenosis. So if you have aortic valve stenosis, that's going to cause left ventricular hypertrophy. You can see dysarrhythmias as a consequence. And for these patients, you can also see sudden death. These patients are usually going to be older, though. So this is a person with like long-standing hypertension or a long-standing valve disease where they have like aortic valve stenosis over a period of time. So here's another image of all of that. So you have your normal heart here. If your left ventricle is super, super thick, that's going to be hypertrophic cardiomyopathy. It could either be hypertrophic obstructive or it could be hypertensive hypertrophy. And then dilated cardiomyopathy. You have thinning of the ventricles, so the walls are going to be thinner, and it's going to be a lot larger. So much more space within those chambers. All right, are you good with me so far? Any questions yet? No questions? Okay, cool. All right, restrictive cardiomyopathy. This is where you have like fibrosis of the heart, and it's going to be very, very stiff. It's going to have a really hard time filling up during diastole. So that's going to result in what? A diastolic dysfunction, right? So you're going to get diastolic dysfunction, and then you're going to get S4 heart sounds with this as well. So the major causes, most common causes, are going to be amyloidosis. That's where you have these proteins that are getting deposited into different tissues. It can affect other parts of the body too, but the heart is going to cause stiffening of the heart. Hemochromatosis, you can also see that there. Hemochromatosis is where you have a disorder in hepcidin. It's one of the main causes. Hepcidin, which is a protein in your liver, it helps to distribute iron and store iron. If you have too much hepcidin, that means you're going to be taking on way too much iron. There's actually a cadaver here that one of the causes of death, it was carcinoma undifferentiated, but one of the things that was on the death list was hemochromatosis. And so hemochromatosis can cause damage to all sorts of different organs, your liver, it can cause damage to your heart. So treatment for something that causes too much like red blood cell formation, for example, you could do iron chelators to remove the iron. Or what else would be something that you could do for a patient that has hemochromatosis? You have too many red blood cells. It's like kind of almost like old school medicine. Yeah, bloodletting. You could do bloodletting. Not like they did in the past, but you could do therapeutic phlebotomy, where periodically they'll get blood drawn out so that it can help reduce the amount of red blood cells. Because people with hemochromatosis, they're also a high risk for stroke because their blood is going to be more viscous. It's going to be thicker, right? So that they're going to be an increased risk of stroke. My best friend's dad, same kid that, well, he's not a kid, he's younger than me, but he's the one that was telling me about that has hypertension. His family has hypertension. His dad gave me his cast iron skillet because his iron levels were way too high. And so the doctor was like, stop using your cast iron skillet. So he actually gave it to me. So if anybody is like anemic, cooking on a cast iron skillet is actually a good thing because you get a little bit of the iron from the skillet in your food. So actually, if you have hemochromatosis, you don't want to use things like cast iron skillet. Kind of cool. Anyways, let's talk about the Frank-Starling law. So This is where you see the optimum stretch of the heart so that you get a really good stroke volume. So if your end diastolic volume is increased up to a certain level, you're going to have a good stroke volume. So if you increase your preload, that means the blood that's coming back to your heart from the venous system. If you increase your preload, you're going to increase your contractility, theoretically, to a certain extent. But yeah, only to a certain point. So where would dilated cardiomyopathy fall in this graph? I think you have the answer on your slides anyways, but if you had dilated cardiomyopathy, this is the spot right here, right? So these are your actin and myosin filaments. So if you see the actin and myosin filaments are everything's stretched out when it's dilated, so they have a really hard time grasping each other and then sliding over each other. And so once you get to this part of the graph, you're going to have reduced contractility. You're going to also have a reduced ejection fraction as a consequence. What about hypertrophic cardiomyopathy? Where would it fall in the graph? It's going to be on the opposite side. It's going to be on the left side of the graph. Right? So if you have, if you're not able to stretch the heart out, if you have fibrosis, for example, or not enough ability to stretch during diastole, then you're not going to get a really good stroke volume. You're not going to get good cardiac output from that as well. All right, let's do a little tiny case presentation. This is kind of fun. So let's read through it together. So you have this patient. She's this young lady. She's 35 years old. She's coming to the emergency department with a chief complaint of chest pain. Fist is over her chest and says it's a crushing chest pain. On a scale of 10, it's 8 out of 10. It's radiating to her left jaw. It's radiating to her left arm. Auscultation is going to reveal an S3 heart sound. Is that systolic or diastolic? That's going to be a systolic disorder. So that means that there's too much blood basically filling in to the heart, and you're not getting a good strong contraction. On the EKG, you actually do see ST elevation. This kind of looks like a heart attack, right? You are seeing elevated troponin levels. Cholesterol is normal. Her risk factors are actually pretty normal. She's pretty good. She has no coronary artery disease risk factors. Angiogram, you're going to see a dilated left ventricle, low ejection fraction. The lady is being left for a younger woman. So her husband of 15 years is now leaving her for a younger woman. So she has a broken heart. Does anybody know what this disease is called? It's actually kind of cool. It's named after it's an octopus cage. So it's called Takotsubo's cardiomyopathy. Takotsubo, sorry. Takotsubo is where you have a broken heart. And the reason why it's called Takotsubo is because it's an octopus trap. So this is an octopus trap that they use in Japan. And when the heart has this syndrome or when you have this type of cardiomyopathy, it looks just like an octopus trap. So this is broken heart syndrome. You hear about people such and such, so and so died of a broken heart. It can happen. I'm gonna have to look into this in more detail, but like one case that I can think of, Johnny Cash, June Carter, they were married for a really long time. June Carter died, I think a year before Johnny Cash died. So June Carter died, and then shortly after he died as well. And so there's often stories that long-term like relationships, somebody has been married for a really long time, one of the partner dies, and the other partner shortly dies thereafter. It could be due to Takotsubo cardiomyopathy. So broken heart syndrome is a real thing. All right. So these are all the cardiomyopathies that I want you to be familiar with: hypertrophic, dilated, and restrictive. Hypertrophic means you have a big buff heart. Dilated, it's going to be thin and ballooned out. And then restrictive, it's really tough for it to get filled during diastole. When you have an S3 heart sound, that's going to be associated with a systolic dysfunction. If you have an S4 heart sound, that's going to be a diastolic dysfunction. That means you're not getting enough blood filling into that. So if you have stiffness of the heart, you're not going to get blood filling in. If you have hypertrophy of the heart, you're not going to get blood filling in. But if you have a systolic dysfunction, that means you have too much blood in the heart and you're not getting a proper contraction. So that's why you get systolic dysfunction. And these are all the different things that can cause the different types of cardiomyopathy. So be familiar with the ones that we talked about in class. So, any questions on any of that? Cardiomyopathies and whatnot. Right on. So let's wrap up with peripheral vascular disease, peripheral artery disease. So we have a little bit left to go through, and then we can probably switch gears. We'll run through some practice questions, and if we have time, then we'll switch gears into CVAs and shock. So peripheral vascular disease and peripheral artery disease, these are super common in the population. That's because atherosclerosis is super common, especially here in the Western world, right? Because of the Western diet, hypercholesterolemia, sedentary lifestyle, all that are going to be predisposing factors to get peripheral artery disease and peripheral vascular disease. The older you get, the more prone you are to getting this, right? Just a factor of aging. When you get older, you're going to eventually start seeing things like maybe hypertension, hyperlipidemia, things like that. Also, vasospasms can kind of cause this a little bit, so we're not going to really focus on vasospasms so much. We are going to talk about vasospasms in the context of like Raynaud's disease, but let's not focus on that right now. Let's talk about diabetes, hyperlipidemia, smoking, hypertension, atherosclerosis. All the stereotypical risk factors for heart disease are going to predispose a person to get peripheral vascular disease as well. Most people don't know they have it. Remember we were talking about angina, and when a person has an occlusion of their coronary arteries that's 50% or more, sometimes they don't even know they have it until they're like climbing a set of stairs, or maybe they're like trying to jog or something and they start feeling chest pain. Right? It's going to be kind of similar to this. A lot of times these patients have no idea that they have it. But when they do have it, they're going to get claudications. So claudications means you have pain in your muscles. So you'll see claudications, intermittent claudications, especially when they're undergoing some sort of task that's like physically exerting, right? So if they have physical exertion, it's going to increase metabolic demand to those tissues. And if you're not getting proper circulation, you might get claudications, which is pain. And then in terms of the pulse, these patients might also have like a really weak pulse peripherally, right? If the vessels are super narrow, you're not getting enough blood flow in there. If you try to palpate the pulse, you're not going to feel it very well. In terms of claudications, let me just make a side note. You can talk to a patient and ask them how they sleep at night. So we talked about orthopnea, that's one thing. But if a person has peripheral vascular disease, you can ask them when they sleep in their bed, do they ever like dangle their legs off the edge of the bed? Some people do that when they have peripheral vascular disease, because when they dangle their leg off, gravity is going to allow blood to flow a little bit better into that appendage, right? And so sometimes they will sleep with their legs off the bed a little bit. For weakness in pulse, when you're doing a physical exam on a patient and you're checking pulses, you got the radial pulse, carotid pulse. You can also check for their dorsalis pedis pulse, as well as your tibial pulse. The posterior tibial pulse is going to be right behind the medial malleolus. Right, that's going to be your ankle bone. So right behind that, you should be able to feel the tibial pulse. And then dorsalis pedis pulse is going to be on the foot, on the top of the foot. You have your metatarsals. So you have your first metatarsal and second metatarsal. If you were to try to palpate the pulse between the first and second metatarsal, that's going to be the dorsalis pedis pulse. Patients that have peripheral vascular disease are not going to have a pulse. It's going to be either absent or it's going to be super faint. So patients with diabetes, patients with long-standing hypertension, you always want to check their pulses peripherally to see if you have a weak pulse or not, or no pulse, which would indicate that they have peripheral vascular disease as a consequence of their untreated hypertension or poorly treated hypertension and poorly treated diabetes. Poor wound healing. Ulcerations are going to be common in these patients. My grandma, when she was alive, she had long-standing hypertension. She actually lived to a really old age. She died when she was 92 years old, so she was pretty old. but kind of poor quality of life towards the end. Like the last 20 years, she had fibromyalgia and a bunch of other stuff. But one of the things that she had was hypertension, and she had it's like right-sided congestive heart failure, basically, because she had really bad pitting edema bilaterally. She would always show it to me when she would like hold her fingers down onto her like tibia, like around her tibia on her leg, and she would let go, and it would like stay indented in there for a really long time. Be like, oh, that's cool, grandma. So that's like really bad pitting edema. So that'd be like +4 pitting edema. That means it stays for longer than like 2 minutes. So that's one thing. The other thing that she would have towards the later years of her life, I want to say like 7 years of her life, she was dealing with ulcerations. So right here, kind of on the interior portion of her ankle, right near the medial malleolus, actually, she had an ulcer there that just wouldn't go away, and it was about this big. So it was about like 3 centimeters or so in diameter. And there was one time that it did go away, and then it eventually came back again. Why do they have ulcers? Because of like poor circulation, right? You're not getting enough blood to that area. So if you can't get enough oxygen to that area, the tissues aren't going to be very, like they're not going to be able to repair themselves. If you're not getting, that's the main thing actually. If you're not getting good circulation, you're not getting like wound healing and wound repair. And then you can have a higher risk of infection, right? Because you're not getting leukocytes there. You're not getting white blood cells to those areas. So you can have a higher risk of infection. Thank God she didn't get infection. She would go to like a wound clinic, and they would like rebandage her up all the time. And yeah, it was pretty brutal. It's kind of sad to see. Very painful. So to test for peripheral vascular disease, you can see lipid profiles. So if they have hyperlipidemia, that might be the reason. If they have poor glycemic control, that might be the reason. You can also do angiograms, so you can see the perfusion of blood in those areas. You can do Doppler ultrasound, so you can actually see the blood flow in those regions. And then the ankle brachial index. Dang it, you know what? I'm not going to play that video because it's kind of beyond the scope of this class. I have a video for this. If you want to look up ankle brachial index and how you test for it, basically what you're doing, you're trying to figure out the systolic pulse, systolic and diastolic in the upper extremities compared to the systolic and diastolic in the lower extremities. And so if the ratio is good and your ankle to brachial index is good and normal, it's going to be around 1. That's going to be the ratio. So that means that you have like a pretty even ratio of upper extremity to lower extremity. But if you have a poor ratio, and if your blood pressure in the arm is higher than what you find in your leg, then if you have a ratio below 0.9, then you have a reduced ankle brachial index. And so that's one way that you can test for peripheral vascular disease. How do you treat it? You could do stretching, aerobics, things like that, right? So like think about how venous blood moves. How does it move? You have valves, right? So you have those valves that allow the blood to move in one direction, but also muscle contractions, right? So like skeletal muscle, when you flex your muscles, that's going to help push the blood back towards the heart. So that's why if you stretch, do aerobic exercise, that can help increase your circulation in your lower extremities. Of course, if you have diabetes, put it under control. Make sure you take your meds. Try to avoid things that would increase your glycemic glucose levels. Control your hypertension. Try to control your cholesterol. If you're smoking, knock it off. You can take antiplatelet therapies. Think about like baby aspirin, for example. Remember what baby aspirin does? We talked about how it's a COX inhibitor, cyclooxygenase. So it would actually be able to reduce thromboxane. So it helps to reduce platelet aggregation. So you can take those types of meds to help thin your blood out. And if it's really bad, you can go into surgery. You can do a stent placement or a bypass placement. Do I have any of those? I don't have any of those videos in here. But this is what peripheral vascular disease looks like. This literally could have been a picture of my grandma's leg. This person's a little bit thicker than she was. She was a lot more frail. But her leg looked a lot like that. My mom, towards the end, when my mom, because she was in Brazil, my grandma, so my mom would like travel out there to Brazil to take care of my grandma for like months at a time. And she would like email me pictures of her leg. So Not really like attractive photographs, but it looked a lot like this. It was like very red. It had this like kind of like crusty scaling uh, as well. That's all due to like poor vasculature. And this little mark right here, it kind of looks like a ulcer that might have healed previously. My grandma had stuff like that too. So like there would be an ulcer, and then over time, if it would heal, it would look kind of like this, very much like that. That's pitting edema. Sticking your thumb in there and seeing how long it stays for. So that's peripheral vascular disease. And then these are other things that you can see too, like the nail beds look really bad in this patient. I mean, at least she's trying, you know, she's got a little bit of nail polish there. But for the most part, the nail beds look really bad. Poor wound healing, ulcerations, all that stuff. These are all things that you see with peripheral vascular disease, peripheral artery disease. And then this is on an angiogram. So here's a normal angiogram. It looks like there's some issues going on over here. You got some blood pooling up here. You got the vessels are looking all dilated. Over here, looks like you have stenosis. Here you also have stenosis. That's something that you might be able to treat with a balloon. So you can go in there with a stent, a balloon it out, then stent it. So here's stenosis. You go in with a balloon and stent, and now that section looks nice and open. So you get better vasculature afterwards.